All right, let's dive into another deep dive. We're tackling a topic you brought to us, critical care for spinal cord injuries. We've got some excerpts from a recent medical review article, and let me tell you, it gets pretty deep.
Deep dive for a deep dive. I like it.
Exactly. So we're talking about what happens after that initial spinal cord injury, because that's where things get really interesting from a critical care standpoint.
Yeah, definitely.
We're talking about serious stuff here. Up to 54 out of every million people in the U.S. experience a spinal cord injury each year.
Wow. That's more than I would have thought.
Right. And it's not just the initial injury we're talking about. There's this whole domino effect that happens afterward, what they call the secondary injury cascade. And that's where critical care can make a world of difference.
Absolutely. It's like, you have the initial impact, the primary injury, but then,
It's not over.
yeah, it's not over. The body kicks into this whole other process, and that's the secondary injury cascade. And that's really what we're here to break down.
Exactly. So walk us through this cascade. What's happening inside the spinal cord in those crucial hours and days after an injury?
Okay, so picture this. The first 48 hours, we call it the acute phase, right? It's like the first wave of trouble. You have all these tiny blood vessels, capillaries getting damaged in the injury, crushed, torn, you name it.
Ouch.
Yeah, not good. And because those blood vessels aren't doing their job, blood flow gets messed up.
So parts of the spinal cord are basically being cut off from their supply lines.
Exactly. And
Yeah.
that's what we call ischemia. These areas of the spinal cord aren't getting the oxygen and nutrients they desperately need.
That's just the first wave.
Oh, there's more. The body, in all its wisdom, tries to fix things by, launching an inflammatory response. But the thing is,
It backfires.
well, it's complicated. Some inflammation is necessary, of course, but in this case, it can actually cause more harm to the already injured spinal cord.
The body's own defense is turning against it. That's rough.
Yeah, it's a delicate balance.
So what happens after that initial 48 hours? Does it calm down?
Not quite. We enter what we call the subacute phase, which lasts from around day 2 to 2 weeks after the injury. And this is where swelling, edema, becomes a major issue.
So more pressure on the spinal cord.
Exactly. It's like adding insult to injury. That swelling just puts more pressure on the spinal cord, further restricting blood flow. And of course, that pesky inflammation is still hanging around, making things worse.
So we're talking about a 1-2 punch here. First, the ischemia, then the edema and ongoing inflammation.
And to make matters even more interesting, this whole process can have lasting effects. Over weeks and months, you can see things like glial scars and cystic cavities forming within the spinal cord.
Glial scars.
Basically, it's like the body's way of trying to heal the injury, but sometimes it creates this scar tissue that can actually interfere with the spinal cord's ability to repair itself properly.
It's like the body trying to fix things, but sometimes it doesn't quite get it right.
Exactly. And that's why understanding this whole cascade, this chain reaction, is so crucial. It highlights why those early interventions, those first few days and weeks after the injury, are absolutely critical.
It's all about damage control.
Absolutely. Every step we take in those early stages is about minimizing further damage to the spinal cord and buying time for it to heal as best as it can. And a huge part of that damage control revolves around making sure the injured area is getting enough blood flow, what we call spinal cord perfusion.
So perfusion is like the lifeline for the injured spinal cord.
Yeah, it's a good way to put it.
It's all about that blood flow, that perfusion, keeping those supply lines open. But I'm guessing it's not always that straightforward, is it? Especially after an injury that can disrupt the body's control systems.
You're absolutely right. Spinal cord injuries, especially those higher up, like in the neck or upper back, can really mess with the body's ability to regulate blood pressure.
And that's a big deal, right? Because we need that blood pressure to be in a good range for proper perfusion.
Exactly. And this is where we run into a pretty tricky customer autonomic dysreflexia.
Autonomic dysreflexia, huh? That sounds intense. Break it down for us. What's happening there?
So basically, imagine the spinal cord like a communication highway between the brain and the body, right?
Okay, I'm picturing it.
And an injury to the spinal cord can disrupt traffic on that highway, especially the signals that control things like blood pressure.
Makes sense.
Now, when something triggers those nerves below the level of the injury, it could be something as simple as a full bladder or even just a little irritation on the skin.
The body's alarm bells start going off.
Right. But because the communication lines are messed up, the brain can't tell the body to stand down. So the blood vessels constrict, blood pressure goes haywire. It's like a runaway train.
Runaway train. That's a pretty vivid image. What are the consequences of this runaway train situation?
Well, all that chaos can lead to a dangerous drop in blood flow to the spinal cord, which is already super vulnerable from the injury. And in severe cases, it can even progress to neurogenic shock.
Neurogenic shock. That sounds bad. Very bad.
It is. It's a life-threatening condition.
Okay, so this autonomic dysreflexia is a big deal. We definitely don't want that runaway train causing more damage. So how do we keep things under control? How do we stabilize blood pressure and ensure that spinal cord is getting the perfusion it needs?
This is where managing mean arterial pressure, or MAP, becomes crucial.
MAP, we're getting into the technical stuff now. I like it. So MAP, tell us more. What is it and why is it so important in this context?
Think of MAP, mean arterial pressure, as the average pressure in your arteries during a heartbeat. It's kind of like checking the water pressure in a pipe. We need it to be within a certain range to ensure that blood, those vital nutrients and oxygen, are reaching the spinal cord effectively.
Okay, so MAP is our gauge for how well that lifeline of blood flow is working. I'm guessing it's not as simple as just getting the blood pressure up as high as possible, right?
Yeah.
What's the strategy here?
You're right. It's not about having crazy high blood pressure. It's about finding that Goldilocks zone. Not too high, not too low, but just right to keep that blood flowing consistently to the injured area.
Finding that sweet spot.
Exactly. And what's really interesting is that the guidelines for managing MAP in spinal cord injuries have actually changed recently.
Oh, a plot twist. I love it when things get updated in the medical world. Tell me more about this shift in thinking.
So for years, the goal was to maintain a very strict MAP target, around 85 to 90 millimeters of mercury. The thinking was, keep it high, keep it steady, no exceptions.
Sounds rigid, like walking a tightrope.
Kind of, but the problem was hitting that very specific target all the time proved to be really difficult. Blood pressure naturally fluctuates a bit, and all that going up and down, trying to stay within those narrow boundaries, wasn't always the best for the spinal cord.
So the constant adjustments were actually doing more harm than good.
In some cases, yes, it created more instability, so the thinking has evolved.
So what's the new approach? More of a balancing act than a tightrope walk.
Precisely. The new guidelines are more forgiving, allowing for a bit more fluctuation in MAP while still ensuring that blood flow to the spinal cord stays consistent.
So wider target range.
Yep, we're now aiming for a MAP between 75 and 95 millimeters of mercury.
Okay, so a bit more wiggle room. Does this change in guidelines actually change how doctors are treating patients? I mean, are we seeing a difference in outcomes?
Absolutely. By focusing on maintaining MAP within this wider range, we're seeing more stable blood pressure overall, which is good news for the spinal cord. It's less about constantly chasing a specific number and more about keeping things balanced and consistent.
That makes sense. So less is more in this case.
In a way, yes. It's about finding that sweet spot and trusting the body's natural ability to heal when we give it the right support.
I like that approach. So for how long do we need to be super vigilant about managing MAP? When does that critical period after the injury start to ease up?
The general consensus is that those first 3 to 7 days are absolutely crucial. That's when the spinal cord is most vulnerable, and we need to be the most proactive with our management. After that initial period, things tend to stabilize a bit, and we can start to relax the reins a little.
So it's like a marathon, not a sprint. We need to be all in for that first week, making sure the spinal cord is getting the support it needs, and then we can start to shift gears a bit. But even then, I imagine we're still walking a bit of a tightrope when it comes to things like medications and interventions.
You're right. We still need to be mindful of the potential risks and benefits of any treatment, whether it's medication to manage blood pressure or other interventions.
It's all about finding that balance, supporting the body's natural healing processes while minimizing any potential harm from our interventions. And that makes me think of another controversial topic in spinal cord injury treatment: corticosteroids. Miracle treatment or unnecessary risk? The debate's been raging for decades. Corticosteroids, right? They've been in the spotlight for spinal cord injury treatment, and it seems like there's always a new study or headline that leaves us wondering, are they heroes or villains?
It's a great question, and honestly, the answer isn't that simple. I mean, the idea behind using them makes a lot of sense, right?
You're right, because we've been talking about this whole inflammatory response that happens after a spinal cord injury. And corticosteroids, they're like the ultimate weapon against inflammation, right?
Yeah. Exactly. They're designed to go in and calm everything down, hopefully reducing that secondary damage to the spinal cord. So you can see why they were initially seen as a potential game changer.
Totally. So where does the controversy come in?
Yeah.
If they work so well in theory, why all the back and forth?
Well, the problem is those large clinical trials that have looked into using corticosteroids for spinal cord injury haven't given us a clear-cut answer.
Oh, no. Not the dreaded mixed results. Give me an example. What kind of things were these trials showing?
So its big ones, the NASCI-7 trial, seemed promising at first. They gave patients methylprednisolone, which is a specific type of corticosteroid, within 8 hours of their injury. And some patients actually saw improvements in their motor function.
Okay, so some positive signs there. But I'm guessing it wasn't that straightforward or we wouldn't be having this conversation.
Right. For starters, the benefits were really only seen in a specific group of patients, not everyone. And there were also concerns about some pretty serious side effects, like gastrointestinal bleeding. Not ideal.
Definitely not. So one step forward, two steps back kind of thing. What about other studies? Did they manage to clear things up a bit?
Unfortunately, not really. There was another big trial, NASCI the third, and they tested out different doses of methylprednisolone, different timings, even compared it to another drug, but the results were all over the place.
A mixed bag again. That's frustrating. So are we any closer to figuring out whether these corticosteroids are worth the risk?
Well, a recent review actually looked at data from NASCI the second, as well as another study on methylprednisolone, and guess what they found?
Don't tell me. No improvement.
You got it.
Yeah.
No significant improvement in neurological recovery after 6 months. Tough break.
So where does that leave us? Doctors are still using corticosteroids to treat spinal cord injuries, right? What's the current thinking?
Yeah, it's a tough one. The latest guidelines from those big neurosurgery organizations, they actually don't recommend just giving everyone with a spinal cord injury IV methylprednisolone.
So it's not a standard treatment anymore.
Not really. And honestly, it's never been officially FDA approved for this specific use. There's just not enough solid evidence to say, yes, this works for everyone.
So it's a case-by-case basis now.
Exactly. It's about carefully weighing the potential benefits, which we can't completely rule out, against those potential risks for each individual patient. It's a team effort, really, involving the doctors, the patient, and their family. Open communication is key.
It's about finding that balance, right? Maximizing the chances of recovery while minimizing harm. And that's what makes this whole field so fascinating, right? It's constantly evolving as new research comes out.
100%. We're always learning, always looking for those breakthroughs that can make a real difference in people's lives.
And speaking of breakthroughs, there's some really exciting research happening right now with a drug called riluzole. It's actually used to treat ALS, but now it's...
Showing promise for spinal cord injuries, too. I've heard about this.
Right. Tell me you know about this. It's pretty cool how it works. So after a spinal cord injury, the levels of this neurotransmitter glutamate can get really high in the injured area. And you know what too much glutamate can do?
It can actually cause more damage, right? Like, it's toxic to those cells.
Exactly. But here's where riluzole swoops in. It basically helps regulate those glutamate levels, kind of like hitting the brakes on that runaway damage.
Okay, I see why people are excited about this. So what have the trials shown so far?
Well, there was this big one, the Riluzole trial, and while it didn't quite hit the mark they were hoping for overall, some of the secondary analyses showed some interesting improvements, even across different severities of spinal cord injuries.
So cautiously optimistic.
That's the feeling. It's still early days, but definitely something to keep an eye on. And it's not just riluzole. Researchers are looking into all sorts of promising treatments for spinal cord injuries, things like cell transplantation, new biomaterials to support the injured cord, even neuromodulation techniques to help restore function. It's a really exciting time to be following this field.
Definitely. There's so much potential for breakthroughs that could significantly improve the lives of people living with spinal cord injuries. And it's not just about these cutting-edge treatments. We can't forget the importance of comprehensive care, addressing things like respiratory function, bladder and bowel control, managing pain and muscle spasticity. These are all essential aspects of life after a spinal cord injury.
It's all connected, right? Treating the whole person, not just the injury.
Exactly. And that's why we need to be thinking about this from every angle, right? From those crucial early moments after the injury, all the way through to long-term rehabilitation and support. It's a team effort, and everyone involved plays a vital role.
Couldn't have said it better myself. Well, folks, that was a deep dive into the world of critical care for spinal cord injuries. We covered a lot of ground today, from that complex cascade of events that unfolds after the injury to latest research and treatment options. And it's clear that this field is constantly pushing forward, driven by both the urgency of the challenges and the incredible resilience of the human spirit. Until next time, stay curious and keep exploring the frontiers of knowledge with us.